So MRD is clearly a great resource because it's a dynamic biomarker for response, and so it can be used rather than for outcome. That of course it's easy to predict outcome after you treat the patient, but it's actually extremely important as a marker to adapt our strategy and, for example, avoid patients certain intensification like transplant, or reducing the duration of maintenance, and so, or maybe doing more and more if the patient is not in MRD negativity. So MRD can be tested in different way because the acronym is minimal residual disease. So you can test in the bone marrow with the classic aspirate and using like NGS or in flow cytometry technology. You can test in imaging, what's called like functional PET, which is basically you create antibodies with a marker that goes where the tumor should be, and you can identify them. And that's the advantage, is that because the tumor is systemic, if you just check the bone marrow, you just check what is behind you, like on your iliac spine. While if you detect like a systemic approach, you have probably more chances to detect what is called the spatial heterogeneity or spatial distribution of multiple myeloma. Finally, there is also another technology that is liquid biopsy, that in multiple myeloma is emerging. There are different ways to do it. There are on circulating DNA, there are on circulating cells. There were a lot of abstract on circulating cells as a marker of aggressiveness for disease and a marker of progression for precursors, as well MRD, like minimal residual disease after treatment. All the results are very encouraging and important, but overall what is still missing, what I think people will have to work hard over the next years, is how we should integrate all these features, because it's clear that some patients are negative and positive at different technology, and so probably these technology are not really in competition but should be probably synergic, and we should identify the best strategy how we can synergize them.